Now we'll get started. Okay, so something everyone's excited about, pharmacology is important. It's something that obviously we use a lot in EMS because that's one of the ways that we can intervene and help people. So we're going to talk a lot about all the medications that are available for first responders, BLS, as well as AEMT. And there's starting to be some blurring of those lines. We'll talk about that today. We'll start off with defining what a medication is. It's a drug or substance that is used to fix an illness. And so you can see the difference is a drug is usually a chemical compound. So there are other things that we consider medications that aren't necessarily drugs. So oxygen could be one. It's a medication, it changes somebody's outcome, but it's not a specific chemical compound that is made to intervene that we use to help patients out. An example, or we'll talk about different routes that you can give these medications. So there's the enteral route, which has to do with Latin pertaining to things that you eat or drink. And so sublingual is actually one of them. Can you think of an example of a medicine that we give sublingually? Nice, underneath the tongue. And oral, you may hear the medical community refer to things as PO, and that means per os, or literally per opening, which is basically, we tend to think of the upper opening that we can swallow with. Another way that you can get things in is to breathe it in. And in the old days, if we weren't able to establish an IV, and before we had IO lines going into the bone, we used to pour things down the endotracheal tube. So there's a lot of medications that we could use, but the more common ones now, there's a few. You think of something we use to inhale, medication, also medication, not the other stuff you're thinking of. What was that? A meter dose inhaler, correct. That's inhaled, and what substance do they inhale? Albuterol. Can you think of another medicine that technically we're going to end up inhaling? Narcan, yeah. We'll talk about that in a minute. The other routes are parenteral, and the most common way is just to inject it. So you can stick it under the skin, you can do it intramuscularly, or you can do it intravenously. So diabetics will take insulin and they'll put it underneath the skin. We can give some medications intramuscularly because there's a lot of blood vessels in the muscles because they need a lot of oxygen. And then obviously, if you can get it IV, that's even better, but that requires a higher level of treatment. So a couple of things that are important to remember about medications. We need to know what the indications are for every medication. You know what the indication is, what the contraindications, meaning what can't you use this medication for. You need to know what the dose is, and that's really important because we really don't want to overdose people, as well as the route. Some medications you can give IV, some medications you can't. Some medications you can inject into a muscle, some ones you can't. As well as the action, because that helps us determine what medicine we're going to use. What's the problem, and what are we trying to fix, and will this medicine fix that problem? So for example, if you're driving down the street and your car stops running and you cruise over to the side, you're probably out of gas. Okay? Changing the oil on the car is not going to fix the problem. So the right medication for that solution is not a can of oil, it's a can of gas. Same thing for the body. We need to know what the action is, what's wrong, and then we find a medication that fixes that problem and try and administer that medication. It's important to note that every medicine that we use has a side effect. Some side effects we don't even tend to remember or think about, but there's a side effect to every medicine, and it's important that when you're going to give these medicines, you need to talk about them today. So, again, a little bit about what each of these specific things. Okay, so remember that in the United States, the only way you can give a medication is on the order of a physician. And since we don't want to have somebody answering the phone all the time at the hospital, We develop protocols that are written and endorsed by physicians, our county medical director, with the recommendation of all the regional medical directors. We develop protocols, and so as long as you stay within that protocol, you're allowed to give that medicine as long as you're following the indications, okay? In the field, sometimes you may feel like you need to go outside that protocol, or something changes, or you need some advice, and that's where we're always available 24 hours a day. So that's important. And it's my understanding that all the agencies are aware of all the phone numbers for all the local hospitals. We have a direct line to get into the ER to get you to a doc. And if you don't know what those are, you should talk to your 20 officer to make sure you know what those numbers are, because we're available 24/7, 365. All right, so your responsibility, we've developed the protocols. Your responsibility is you have to know these protocols. If you don't know these, to sit there and say, well, I didn't remember this, or I wasn't sure about this, is not an excuse. Part of the training is you have to know what they are. And all these indications, drug dose, all those things are available. They're available online at the county website, which is emsoffice.com. They're available here at the station in a big binder, printed out for your use, or you can pull out your phone and you can look for this logo. It's in both the Android and the iOS web store, the App Store, and it's called the PPP Agency app. I don't know why they came up with that name. But this is what it looks like, and if you pull it up, when you first open it up, it'll ask you for what agency you're with, and you say Spokane County. You'll see tons of agencies in there from almost all states in the United States. You just go down to Washington, pull up Spokane County, and it will instantly download all the protocols for the county, including paramedic levels. All the entire county protocol are all in there. So that's available to you 24 hours a day. Okay? Remember that not only do you have to know what to do, and you have to feel confident in doing it, you got to use the proper technique and the proper precautions, not only keep you safe, but the patient safe, and that's what we're going to review today. So, in addition, you have to document what happens. So, in your field report, you have to say, well, this is what I see, and this is what I think's going on, so I'm going to give this medicine, and the job's not done. You have to describe afterwards what happened. Did the patient get better? Did they get worse? So there's responsibility in giving medication. You have to document what happens after the fact. And in addition, you need to understand what these medicines do. We want to make them better. So, we will move on. Hopefully you haven't seen this here in the States, because that would be rather tragic. Okay. So in pharmacology, there's some big words. One of them is pharmacokinetics. Kinetics means how things move. And when we talk about medications, we talk about how the medicine gets moved into the body. And we're not going to get into too many details, but I just bring up these terms so that you're familiar with them. In particular, pharmacokinetics talks about how long does it take for the medicine to be absorbed and how long does it last. Where does it go in the body? Sometimes it doesn't go everywhere. Sometimes it won't go to the brain. Sometimes it will. And how is the medicine broken down and excreted? Those things are not necessarily details that you need to know the specifics of, but they're an important part of pharmacology. And so here's an example. We use medications and we can measure how they function in the body. And so, if you look up here, you can see here's a time point 0. Somebody takes a medication and the level of the medicine spikes and then it starts to drop over the course of the day, and 12 hours later it's gone down quite a bit. And so it's knowing the pharmacokinetics of a medication that the pharmacist and the physician sit there and say, well, this medicine needs to be taken twice a day. Because after 12 hours, it's pretty much worn off in the body and we need another dose. And so that's what helps us determine how frequently the medication needs to be given. You'd think there that it would be nice to only take a medicine once a day. Most people would agree. But in certain instances, if you only take that medicine once a day, it may result in a huge spike, and you'll be able to last the whole 24 hours, but this huge spike may not be desired. And so really, the manufacturing of medicines is trying to figure out, well, we don't want too much, but the longer we can make it last, then the better patients are compliant. And this is pharmacokinetics. So that's why it's important. If the medicine says take it twice a day, you got to take it twice a day, because if you only take it once, it won't last long. There's another medicine called pharmacodynamics, or another term, and what it affects is trying to study how the medicine is influenced by different things. We're not all the same age. We have men and women, and we're just starting to really fully understand that we used to not even think that male versus female was an issue, but now we're starting to learn that some medicines are processed differently, and maybe we have to start prescribing them differently based on whether you're a male or a female. But we know that age definitely makes a difference, and in some cases, body weight can make a difference. And we know genetics play a role too. So all these things come into play when the manufacturer comes up and says, here's our recommendations for when the medicine needs to be taken, how it affects the body. So pharmacodynamics also pertains to the mechanism for what the medicine does. So for example, if we take albuterol, we know what the medicine does. It causes smooth muscle to relax. And so we'll have a predicted response. We think that the oxygen should go up and people should be able to breathe easier. And so by understanding what a medicine, what its mechanism is supposed to be, then we can understand what patient. Okay? But there are other things that can affect how that medicine gets in. So for example, if their mouth is dry, then the medicine may not be as absorbed as well. But we also know that through pharmacodynamics that they may have side effects. And so how many people have given albuterol and the patient starts to seem really anxious and jittery? That's a very common side effect. In fact, people that don't have asthma or don't have COPD tend to really get nervous about that because they've never experienced that, and their heart starts to race. So it's important to know about those things so you can tell the patient. It's also important to know that in some cases, the medicine can actually cause harm, although we think that it's rare. And so we'll talk about the contraindications. So somebody that has really, really high blood pressure, in the case of albuterol, it's something to think about. They're all part of pharmacodynamics, unpredictable reactions. So, for example, if you get this much response from a medication, if you give it again, will you get twice the response, or will you only get a little bit of increased response? And understanding this will help us better evaluate, treat the patients. A good example of that is narcotics. The heroin addicts know this. They know that after a couple of months of using it, it takes more heroin to get the same buzz, because their body becomes used to that, and this is part of pharmacodynamics. Okay? Right. So, other things we need to know about: how to store the medication. There are some medications that are very sensitive to environmental conditions, whether it's temperature or moisture or even light. So, for example, nitroglycerin comes in a dark vial, a dark brown vial, and it's sensitive to light, and in addition, it's sensitive to air. So I've had patients that they open the vial, it's brand new, they open it, and then their pain goes away, and they don't take any medication. They screw the lid back on, and then they keep it in their pocket, and they're like, well, it came with 30 tablets, and a year later I haven't used any, so I'm not going to throw it away. So they hang on to it. The problem is you've broken the seal, and the nitroglycerin has been exposed to the air, and the air will oxidize the nitroglycerin to a different compound that no longer works. So you'll have patients that are having angina-like chest pain that are taking their nitroglycerin and they're not getting better. But then we'll have the Paramedics on the scene, they'll open their bottle, give them a nitroglycerin, their pain goes away instantly. It's because they've documented the timing of when these bottles were opened. And so, for example, nitroglycerin, after 6 months, it's done. Whether you've used it or not, it's no good. So how the medicine is stored plays its expiration date. All right. So what do you think? That's going to work? Either the train's going to jump the tracks and cause a bigger accident, or the hose is going to get trashed. But good. All right. So let's talk about some common medications that are available and are part of the Washington State protocol for both BLS and AEMT. And these are the list, categorized by cardiac, respiratory, and metabolic conditions. Okay? There are different ways that the drugs can be stored. They can be stored in ampules, which are little glass vials that look like bullets. And you break the tip off, and then you can get to the liquid inside. There are multi-dose vials or single-dose vials. There are syringes that need to be mixed up, and of course we try not to do that in the pre-hospital setting, as well as pre-filled syringes, and then other vials that are stored for. So, for example, here are the ampules on the left. You can see them bullet-shaped, and there's a little score along that neck. And you bend them at the tip, and the neck breaks off, and we can suck out the liquid. The most common thing, obviously, we don't like to put those on EMS rigs because, I mean, since when are you guys driving on smooth roads, you know? And so typically we have them in these multi-dose vials or single-dose vials that look like this. A small vial that's used once has enough medication for one dose. And so basically you pop the top and you get access to the rubber. There's also single-dose pre-filled syringes. So here's an example of Narcan that comes in a plastic container here with the glass vial in it, and you feed it in the bottom and then just inject it. And you can hook this into an IV, attach a needle to it, or you can attach this, which is called a MAD device, and we'll talk about that in a minute. So it's important when you get out medications, you've got to look at the medication vial. It may sound simple, but it's really important. You've got to look at the vial and make sure that the medicine that you want is the medicine you have in your hand, because the worst thing you can do is give the patient the wrong medication. Okay? The next worst is to give them the wrong dose. But it's also important to look at the expiration date. Every medication that's packaged, whether it's in a box or a vial, will have an expiration date on it. Okay? And then it's important to look at the dose and the concentration. And we'll teach you what those doses are and the concentrations are, because again, you don't want to give the wrong dose. So patients have rights. And when it comes to medications, they have these 6 rights. They have the right to be the right person for the right drug, to get the right drug, the right dose, at the right time, the right route, and then they have the right to have it documented as to what happened before and after. And these are important because you have to fulfill all of these. So, again, the BLS medications, albuterol, if they have their own nebulizer at home or they have their own meter-dose inhaler, you can assist them. Aspirin should be on all the rigs. Epinephrine, we'll talk about giving an IM, intramuscular injection. Nitroglycerin, if they have their own nitroglycerin, you can help them with it, as well as oral glucose. Oxygen, we list that as a medication and intervention because it does change things. Narcan we'll talk about here that's recently been changed for BLS to be given IM or by MAD device. All right, and then there's the ILS medications or the AEMT medications, which include, we stock albuterol on the rigs so that you can use it via nebulizer here. Normal saline, again, that's a medication. Narcan or naloxone intravenously, as well as an amp of D50. So that's basically glucose that's already in solution that you can give in an IV, these medications. Hopefully you've never done stuff like this. Okay? So, albuterol. The generic name is albuterol. You may see it as a trade name as a Proventil inhaler or Ventolin inhaler. But basically, this is how it works. It's a charged gas cylinder that you shake up and down, and then that bottom part, they put their mouth around it and squirt. And as they squirt, they're supposed to breathe in. And that's the fog, that's the aerosolized medication that they breathe in. And the mechanism of action of albuterol dilates the bronchi. So those are the breathing tubes in the lungs. So you can see here on the left, if there's something that's been inhaled that's irritated the lungs, one of the lungs' defensive mechanisms is to tighten down and constrict that airway so that no more of that stuff gets in there. The problem is that if it all constricts, then it makes it really hard to breathe. And those of you that have had this happen, I usually tell patients breathing is a good thing. And so we want these airways to dilate, and albuterol is a way to get that to happen and to just bring it directly into the lung. Talk about how it works. So the indications for albuterol use is shortness of breath with wheezing. And it's interesting because I'll be at the hospital, and usually multiple times per month I'll have paramedics bring patients in. Yeah, the patient's complaining of shortness of breath. What'd their lungs sound like? Bad. And then I can tell they weren't listening. Because not everything that's shortness of breath needs albuterol. It's shortness of breath with wheezing because those airways have constricted and it's causing the wheezing, which is turbulence. That's how albuterol is going to help. So there are some people that are in congestive heart failure. They don't have wheezing, but they're short of breath. And giving them albuterol is not going to help them. In fact, in some cases, may make them worse. So you should be able to listen and hear wheezing. Hear somebody wheezing, that high-pitched squeaks. Okay? So people that have known asthma or COPD or emphysema, or in some cases, there's always the caveat indication. If medical control tells you to give it, go ahead and give it. Okay? The side effects of albuterol, the medication works on a receptor, and this receptor also happens to be on the heart. So as a side effect, some of that medication is going to cross into the blood and attach to the receptor on the heart, and it's going to make the heart beat faster. So people tend to get tachycardic. And as a result, they sometimes will become really jittery. Okay? Their blood pressure also is going to go up because their heart rate's going up. So the contraindications, or the things that you should use caution about giving the medication, is hypersensitivity. Now, literally 2 nights ago, I had a lady who said, I'm allergic to albuterol. And so I sat there and thought about that, and I tried to explain to her that her body makes medicine that's exactly the same as albuterol to help the muscles relax. And I've never seen anybody that's allergic to albuterol. And after finally digging into it, she stated that it made her mouth become dry. I said, well, that's nice. And I understand that that's uncomfortable, but that's not an allergy. That's not a hypersensitivity. Especially when you're having a hard time breathing. Would you rather have a dry mouth or would you rather breathe? And when I put it in that context, she chose breathing. And so I gave her the medicine, and imagine that. She got better. So a hypersensitivity means a very severe, serious reaction. And I understand sometimes in the field you may not have that luxury of time or location to be able to sift through that. And so we encourage you to use your better judgment. Okay? So hypersensitivity, a severe reaction where they can't breathe, or their blood pressure tanks, or they have seizures, those are bad things. Okay? In this case, for albuterol, sometimes people will say, I have really bad heartbeats. Now, I said earlier, albuterol is going to cause everybody's heartbeat to go faster. That's okay. So I'll ask people, gee, The last time you had this, did you have to go to the hospital to have your heart checked out? No? Okay. That helps me understand the severity of it, okay? If the patient is on a medication called digitalis or digoxin, you should use caution and call medical control, and we will step you through that. It's very rare, but as you go through their medication list, before you give a medicine, you should know what medications they're on. Question?
It's the only way to know if they're hypersensitive is if they've taken it before and have those.
Exactly. So usually you'll tell people, hey, I'm going to give you some medicine to help you breathe easier. Oh, what is it? Albuterol. And usually that will prompt them to say that something's going on, and so you dig a little bit. But if they've never had it before, you're good. So the cautions about giving albuterol is if somebody already has chest pain, and what we're talking about is chest pain that is like cardiac-related chest pain. What does typical cardiac-like chest pain feel like? What do people describe it as? A crushing, heavy sensation and a pressure. That's correct, okay? So that's important because the county protocol says cardiac or angina-like chest pain. So if somebody has sharp chest pain, that's not typically angina chest pain. If they feel like there's a band around their chest and they have a history of asthma, that makes sense because their lungs are tight. If they don't have a history of asthma and they're feeling pressure on the front, that's something you should be concerned about. Okay? If their blood pressure is really high, remember I said we know albuterol is probably going to make your blood pressure go up. So if their starting blood pressure is over 180, you should use some judgment or call medical control and say their blood pressure is really, really high. What do you think? Should I give this medication? And we'll ask you some questions to try and sort that out, okay? Also, people that have problems with hyperthyroidism, this can also make their heart beat irregularly, though most people. All right, so here's how you do it. If they have their own inhaler, as a BOS officer, you can help them give that. So hold it up, tell them to breathe, and as they breathe, you actuate the device and get the spray in. You'll see that some people have what's called a chamber in front. It's a plastic hollow tube that fits the MDI, the meter dose inhaler, on one end, and then you put your mouth on the other end. Basically what it does is some people just can't synchronize it. They can't breathe in and squirt at the same time. I know. Some people have a hard time doing it, especially the kids. So what they do is they squirt it, it fogs up the tube, and then you just inhale the fog. That's all that is. It's just a chamber to make it easier for them to get that in rather than it ends up on their tongue or it ends up on their face or it goes somewhere else. So if you see that, the studies actually show that the medicine gets deeper into the lungs when they use that plastic tube in front. So for AEMTs and ALS, you can use it by what's called SVN, small volume nebulizer. So the albuterol literally is in a little liquid. You pour the liquid into this plastic device in here and hook it up to oxygen tubing, turn the oxygen on, and it starts to bubble through the albuterol, making a mist, and they just hold the piece there and just breathe through their mouth, in and out, and the medicine goes in. And I think most of you have seen that, right? These small volume nebulizers. It's very effective. All right. Totally awesome. You know, Darwin Award. All right. So the next medicine, aspirin. Okay? That's the generic name. It works as a blood thinner and is used for heart-related patients as well as a few other things. Basically, it makes the not stick so much. So you'll recall that the blood has red blood cells in it and then these tiny little platelets. And when the platelets get activated, they become sticky and they help the red blood cells as well as a substance called fibrin start to stick next to each other to form a clot. God designed it this way so that if you're out in the forest and you walk by a tree and you cut your arm open, you don't bleed out. the body starts to form a clot so that you don't lose all of your blood. And the platelets are a key part of the process. Here's an electron micrograph that's been artificially colored to show you that process. And the red blood cells are in red. The blue is the fibrin strands. Think of them like sticky string. And the platelets are purple. And they help tie everything together. So if you wanted to know how this works, there's multiple clotting pathways in the human body that starts with factor 13. Factor 13 gets converted to factor 13A, which then converts factor 11 to 11A, which then converts factor 9 to factor 9A, and 9A comes down and activates factor 10 to factor 10A. But then it gets more complicated because protein S can block this, but it requires factor 8 and factor 5 to activate factor 2, which then makes fibrin and then forms a clot basically over here where you have platelets that get activated and things stick together. Aspirin blocks this process up here. That's right. There's a test afterwards. You have to remember all these words. There's a test afterwards. I had to give a biochemical lecture years ago, so I'm just trying to get mileage out of it. So it blocks this pathway, and so the platelets don't stick. The fibrin is there, but the platelets aren't activated, and so you get thin blood. So that's what we're looking for heart patients. So we know, after decades of research, that aspirin, which is like 2 cents, will have a dramatic effect on saving people's lives when it comes to heart disease compared to these $1,000 medications. Aspirin is still that significant. However, it's not without risk. It can cause heartburn and upset stomach, nausea, vomiting, and in certain situations can cause bleeding in the stomach. It's a blood thinner. It also blocks that other enzyme called cyclooxygenase that's used in the stomach to protect the stomach. And so in certain people, very rare people, they know that they will have severe bleeding and we don't give them aspirin. Those people will be very clear and say, yes, my cardiologist has told me I can't take aspirin. And in that case, I would honor that and not give them aspirin. Everyone else, look, dude, do you want to die or do you want to take this aspirin? Because this will definitely help you the sooner that gets on board if it's heart-related chest pain. Okay? So, some asthmatic patients, the asthma can kind of mess up their breathing. Pediatrics, you don't want to give aspirin to. Do you remember why? Never give aspirin to children. You know why? You know that rule, right? Never give aspirin to children, ever, ever. It's called Reye's syndrome, okay? Has a bad outcome. Children don't get aspirin, they get Tylenol. Never give aspirin to kids. All right, so we talked about the possible precautions. The dose is 325 milligrams, or, this is awesome, 4 baby aspirin. I just told you not to give it to kids. But we have baby aspirin, and it's just the small version. And the baby aspirin dose is actually 81 milligrams. So if you do 4 times that dose, it's 324. So it's pretty much the same as a standard aspirin. Most of us carry the small baby aspirin because they make it so that you can chew it and absorb it faster. Isn't that what you guys carry on AMR? It's 4 baby aspirin. They chew it up and it's in. I'm not exactly sure what we carry. 4 babies? And chew them up. Okay, good. So some people may say, well, I already took 2 aspirin this morning. How many did you take? Are they 81 milligrams? Yes, we'll give them 2 more. Get them to 320. And obviously, believe it or not, there are 2 routes to get aspirin into your body. There's this route, and then there's this route. Most people elect for the former rather than the latter. All right. Can't you just see what's going to happen with this patient? It's going to end bad. Despite the spotter, it's going to end. Okay, we're moving through. So nitroglycerin. Nitroglycerin is used to blow things up. But in human beings, we use it to help cardiac-related chest pain. The trade names that you may hear is something like Nitrobid, Nitrostat, Nitrolingual, NitroQuick. You can tell the manufacturers are really creative. They just put nitro in the word, which is good. It makes it easy for you to figure out. What nitroglycerin does is that compound, if you hook it up to an explosive device, will blow up. In the human body, that compound goes in and it forms a chemical reaction that tells muscles to relax. Kind of like albuterol, but it's in blood vessels. And so a blood vessel that may be clogged will start to open up and dilate. And so the problem with people that are having a heart attack, they've got a clogged artery. So we're trying to get that artery to relax a little bit, to allow a little bit of blood to squeeze around that clog until it can get opened. And so if a little bit of blood gets past that clog, then the pain gets better. And if you've seen anybody that has cardiac-related chest pain, angina, you give them nitro, a lot of times they'll say, oh yeah, that pressure's going down. It's exactly what's happening. It doesn't take long, a minute or 2 minutes, and it starts to kick in. It's awesome. Okay? So it dilates those blood vessels. The challenge is that those receptors are also on other smooth muscles of the body. So things like the uterus, the bronchus, so they'll breathe a little bit better, as well as the intestines. And we don't worry so much about those side effects. It helps the heart a lot. So the indications to give nitroglycerin is cardiac-related chest pain, just like we talked about. Pressure, heavy sensation. Or if the patient says, you know what, this feels like the last time I had a heart attack, I'd trust them and go ahead and let them do it as long as they meet these criteria. They may also have congestive heart failure. And those of you AEMTs or ALS, you'll hear crackles in the lungs and their oxygen levels may be going down. Nitroglycerin will help them, okay? Or if medical control requires it. The side effects are it can lower your blood pressure, and, oh, Darren, what do you think? Half the patients get headaches? Around that? Somewhere around there. Maybe a little less, a little more. They'll get headaches and maybe feel a little lightheaded, but it definitely will help their chest pain if it's cardiac-related pain. Things that you want to be careful about giving nitroglycerin, contraindications, head injury, because it can lower blood pressure. If they are already starting with a low blood pressure, do you really want to give them medicine that's going to lower their blood pressure more? That's a little dicey, and so you'd want to call medical control. Obviously, infants and children, bad combination. Okay? If the patient's already taken 3 doses of nitroglycerin, you ought to call medical control and see if another dose is indicated. And we'll step you through that. This is important. And the last contraindication, the last thing that would keep you from giving nitroglycerin is what? If they're not prescribed it, so if they've never had this before, but you roll on the scene and it sounds like chest pain, we will trust you to go ahead and give it. Can you think of another reason that's an absolute contraindication? If you have done this, you cannot give nitroglycerin. What is it? Good. Somebody needed a real big dose. So if the patient is taking Viagra, Levitra, or Cialis, they can't take nitroglycerin. It can cause their blood pressure to plummet. In fact, we figured this out because people started dying. And there were some lawsuits and finally understood the interaction of these medications. So if they've taken Viagra, but it's more than 24 hours, you can give it. So there's a 24-hour washout, except for Cialis. Just like you've seen on the commercials, it lasts all weekend. So the same thing happens. It lasts all weekend. No nitroglycerin for you. Okay? So you got to ask. It's critical because you can kill somebody if you give them nitroglycerin. Okay. The dose is sublingually Some people may have the spray bottle, and they just squirt it under their tongue. I've only seen that once here in Spokane. I've seen it other places, but I don't see it prescribed very often here. And the dose is 1 tablet underneath their tongue every 5 minutes, up to 3 doses. And then after 3 doses, you're done. But make sure you take a blood pressure in between every dose, okay? And this is what it looks like. You can see these tiny little tablets. And there's the spray bottle. And notice that the person has a glove on. You don't want to get this nitroglycerin on your hands. It can be absorbed, so you should use caution. And like I said, it's got to be in the dark. It's got to be airtight. And once you open a brand new bottle, you should write the date on there, because then 6 months, like I said earlier, we got to throw it away because it's no good. The nitroglycerin gets oxidized to a sister compound that's no longer active. Yeah. We do things a little different in the United States. Yes?
Would you be all right if you gave aspirin and nitro? Or would that...
Absolutely. The question is, would we be okay if you give aspirin and nitro? Absolutely. The first thing that I would give is the aspirin. Get that on board. Sometimes people, if they have a heart attack in a particular spot, if they take nitroglycerin, it may start to help their pain, but they could pass out. And so that's why I would give the aspirin first and then give the nitroglycerin. But absolutely, both will be critical to helping the patient.
Is there like a time when we should wait before?
Nope. Just make sure they've chewed up the aspirin and it's gone. And then make sure you have a blood pressure. And you've taken a blood pressure, and if you got a good blood pressure, then go ahead and give the nitro. Excellent question. All right. Glucose. Well, they actually have a trade name, Instaglucose and Slutose. You can see they got real creative here, and the mechanism of action is it increases the sugar. As you might guess, we use it for diabetics that their glucose is really, really low. And how do you define that? Somebody that says, I'm a diabetic, or you can tell they have one of the wrist bracelets, or a family says they're diabetic, they're confused, and then you check their blood sugar, and it's low. Tell me, what's a low blood sugar? 15 is definitely low. Also, that was a poorly worded question. At what point, that was nice, at what point should you sit there and say, okay, this is too low, I'm going to give glucose? So the general guidelines are if you're below 60 and symptomatic, confused and weak, most brains will function on 60 or higher. They'll do okay. If you're below 60 and you're starting to feel confused or they're somnolent, then that's an indication to give it. The side effects of giving oral glucose is they just get a sugar buzz unless they're truly unresponsive and they can't swallow, and then they aspirate because you gave it to the wrong person. Yes?
Diabetics usually run about 100, let's say a diabetic run 180. You check them, they have symptoms of low blood sugar, and they're at 70. So you do it.
So the question was, some diabetics, despite their best efforts, live in the 180s, and so they're down to 70 and appear to be symptomatic. So relatively for them, they're feeling a little low. Is it okay to give it? The county protocol says that would be okay if they're feeling symptomatic, confused, disorganized, and somnolent. It's a judgment call, and we trust you to make a good call. The side effect is if they don't need it and you give it to them, it's not really going to hurt them as long as they don't aspirate. So just make sure that they're not that profoundly altered. Good question. So the contraindications, like I talked about, is an unconscious patient. You run the risk that it goes down to the airway, which would be bad, or if for some reason they couldn't swallow, okay, or a known diabetic who's confused but they've been out of their insulin. Hopefully you would figure this out when you do the finger stick and you're like, they're confused, but the monitor says high. That doesn't mean that they need more glucose. It means they have sky-high glucose, and it's the opposite direction. So while you found the confusion, it's not because of low blood glucose, it's because it's high. Okay? So don't give it in those situations. So the way to give it is to give it orally. Some diabetics will carry around a Jolly Rancher when they start to feel a little low, and they'll pop that in. But somebody that's really sluggish, we've got the oral glucose solutions, and what you do with kids is you just pull out their cheek a little bit and squirt a little bit in their cheek, and then it just kind of mixes with their saliva, and as long as they're awake enough to handle their secretions, and you go slow, they'll slowly start to swallow that, and it'll pick them up, okay? Rather than give them the whole toothpaste tube of gel at once, and then they're kind of gagging on the stuff, okay? So between the gums, all right? Now, for ALS and AEMT, you can give D50, dextrose 50%. It's basically the same thing as the oral glucose. The benefit is that if they're unresponsive and they have a glucose of 15, then they can't take it orally. You can establish a line and you can give it intravenously. You should be able to confirm it with a glucometer. Be careful. In people that are under 16 years of age, a whole amp of D50 is not the recommended dose, and you should contact medical control to get advice before giving an amp of D50 to a child. I'll say that again. You should consult medical control before giving an amp of D50 to a child. If they're low, call medical control, and we'll help you through. All right. See any problems with that? Maybe? Oh, that's scary. Okay, so oxygen is actually a medication, and it increases the oxygen levels in the blood. And I'll just point out, do you guys know who this guy is?
Quite a handsome man.
Oh, geez. That does happen to be me a few years ago, before I went into a burn building in Cleveland. So oxygen, as you know, really helps things out. People feel better. In fact, foolishly, there are places that'll say, hey, we're going to help you feel better. We'll sell you some oxygen. Come over here to our oxygen bar for only $9.95 every 29 minutes. You'll feel better and you'll be smarter. I got some real estate on the moon I want to sell you too, if you fall for that. Doesn't work. For patients that need it and have underlying medical problems, supplementing their oxygen can help. In particular, patients that are experiencing shortness of breath, such as COPD, asthma, pulmonary edema, congestive heart failure, bronchitis, pneumonia, infections, or if otherwise authorized by medical control. Obviously, if you're concerned about airway deterioration, it's good to get more oxygen in, so that if their airway becomes compromised and you have to use an advanced airway, then that gives you a little bit more of a wiggle room. Have you guys seen the new gel airways, the eye gels? Okay. So slowly those will probably start to replace the Kings. As we rotate through our cycles, I know City is already starting to trade those out. It looks like an LMA with just this gooey gel-like thing. You just shove it in and you're done. You don't have to blow up a tube, don't have to carry a syringe. You just push the thing in. It's pretty cool. We'll talk about it later, but advanced airway, okay. The side effects of oxygen in rare situations are people that have severe COPD or emphysema. It can make them stop breathing. It has to do with the chemistry of the blood. It has to do with the sensors in the body that tell you to breathe. There are sensors that measure carbon dioxide in your blood, and that helps you determine breathing. And then the fail-safe sensors are the ones that measure oxygen. The vast majority of us breathe every day based on our CO2 sensors. In COPD patients, their CO2 is already screwed up. So if you screw up their oxygen sensors, they stop breathing. So those are rare. Typically, those patients are already on like 4 or 5 liters nasal cannula oxygen. So my advice is that if those people already have low saturations and they live at 4 liters nasal cannula, you should probably bump up the level of service of that call and consider calling medical control, because they're going to get pretty sick pretty fast. Okay? I'm not saying you can't give oxygen, and obviously if their saturations are dropping, you do what you need to do, but in those really brittle people, if you give them oxygen, you got to be ready to supplement them, and you may need to bag them or provide an alternative airway. Okay? The contraindications, really so, like I said, you just have to be careful with COPDers and children. Remember, these little kids, their lungs are really, really small, and you put 2 liters on a little kid, and it's like they're sticking their head outside the window while you're going 55 miles an hour. You're just blowing their nose. 2 liters is tons. In peds, we measure flows by 1/4 of a liter increment. Okay? So with little kids, with a nasal cannula, go tiny amounts, or you can use a non-rebreather if necessary. Okay? Don't forget, how many people, well, so I've been on long transports, and all of a sudden I've got a patient that's intubated and their oxygen levels are going down, and I've been in the back of a helicopter, I've been in the back of an ambulance, and it finally takes me probably 30 or 45 seconds of fear and trembling to finally realize I drained the oxygen tank, because depending on how much flow, you're going to burn through that tank. So just keep that in mind. If you're going on higher flow, take a look at the tank levels and have a backup ready so you don't burn out. I think everybody's been there. Haven't you been there, Darren? Burn through O's? I mean, you guys have probably burned, yeah, got all of that. That Darwin. Okay, so naloxone, the trade name for it is Narcan, and it blocks the narcotic receptors in the body temporarily. It's a competitive antagonist. So if there are any opiates in the body, this medication, where the opiate fits on the receptor, this medication will come in and block it so that the receptor doesn't trigger. So it reverses opiates. So the indications is if you're suspicious for an opiate overdose. That's defined as depressed level of consciousness with pinpoint pupils. Because remember, using narcotics will make the pupils go really, really small, okay? And their respiratory rate is less than 6. This is the county protocol. Or, again, the caveat is if medical control asks you, what do you think are the side effects of Narcan? Hypersensitivity? Yeah. You can tell that vomiting will do it too. You can tell the people that have given it, it's, poking the bear, poking the sleeping bear or waking the sleeping giant. If you're not careful, all of a sudden they're going to wake up, and a lot of times they get pissed, even though you just saved their life. Okay? They can have nausea, vomiting, they can start sweating, their heart rate will go up, their blood pressure will go up, they can start shaking, and they can start peeing and pooping on themselves. You can imagine that's not a very fun person to be around in the back of a bus. Okay? So just be prepared that this can happen in certain circumstances. Okay? So just in your mind, take the opposite of the person that's on a narcotic overdose. Their blood pressure's low, their respiratory rate is low, they're unconscious. You reverse that, you get the opposite. Blood pressure's high, heart rate's high, respiratory rate's high, mental status is markedly increased. So they're just polar opposites. I saw a hand. Question?
Is that more of a symptom with the withdrawal from heroin than necessarily symptoms or side effects of Narcan?
Well, so is that the question was, is that a symptom of the Narcan, or is it the effect of the withdrawal from the opiate? It's probably a little bit of both. in that you've just abruptly reversed the effect of the opiate, and so you've taken away all of the depressive actions, and so the central nervous system instantly just ramps up. So it's probably a little of both. I don't know. Maybe we're getting semantic. Splitting hairs. All I know is A plus B definitely equals C sometimes, depending on the severity of it. I've had patients do this exact same thing where they stop breathing. I give them a big dose of Narcan, and they literally jump off the bed in the ER and start running circles. Yeah. Okay. All right, so a couple of cautions. Number one, the medicine will only last for about 10 to 20 minutes. And then after that, the medicine gets metabolized in the body and it disappears. So if they have a huge level of narcotics, when the antidote wears off, the narcotics come back and they become somnolent. They can become somnolent and stop breathing again. So just keep that in mind, that you've got to pay attention, because depending on when your backup arrives or during transport, it may take a while to get to the hospital and you can burn through that Narcan. So the rule is then you've got to be ready to give another dose or support their airway. Okay? Also, a precaution, like I said, is they may become combative. And if the patient's pregnant, please give medical control a call and let us know, because that can get kind of complicated. We obviously have to save the patient, but there are complications associated with the pregnancy and keeping the patient safe, and we will step you through that. Now, the dosing for Narcan in the BOS protocols in the county says to give 2 milligrams of Narcan, and it's typically because it can be given intramuscularly or intranasally via a MAD device. At District 10, we have elected to use the MAD device. I don't want you to give this intramuscularly. And so it's just really, really easy, and you just spray it up a nostril. For IRS, if you're going to give it IV, if you give 2 milligrams IV, you will definitely waken the sleeping giant, and life will become infinitely more difficult for you. So,
now, did you not, even on the ILS side, do you not want an IM at all either?
no. So just pick MAD or pick IV. Okay? Just pick one or the other just to keep it simple. So with the ILS, you should give in 0.4 milligram increment. Use a MAD device. MAD stands for mucosal atomization device. The mucosa is the lining of the nose. So what happens is you have this glass syringe that has the medicine in it. You have the plastic adapter. The glass syringe goes in the bottom of the plastic adapter, and if you need to, you can hook this up to an IV and give a small dose, or you hook it up to this stopper device and just put it in one nostril and squeeze, and it aerosolizes the medication. So, in District 10, we're converting our epi boxes to contain both of these. So it's really important that you look at these boxes. Okay? The doses for the epinephrine and the Narcan are here. The Narcan's all one. So what will happen is the Narcan's on top, and it says naloxone on it, and it's got both of those things in there. And then sitting right next to it is this little device here. You can see it's got the foam little top. It fits, it's a Lure adapter. It fits on the end of the Narcan barrel syringe. You just tuck it into the nostril, even if they're unresponsive. If they're awake, they're going to fight you. So that's an indication that they probably don't need it. Why are you shoving that up my nose? That's contraindication number 1. Don't fight the patient. Okay? So here, you would just put it in the nose and just squirt it up in the nose, and it'll spray. Some of it may turn into liquid. It's okay. They won't choke, gag. They may, but it won't hurt them. Okay? So District 10, that's how we've stocked the box. It's the top, and the doses are all listed here in the lid on both sides. Okay? That's really important. How you do the MAD device. Yes, sir.
Real quick, county protocol does say to do it's you put half of the syringe up one nostril and half the syringe up the other side, so it's 1 mil on each side of the nostril. I don't know why exactly they want it both sides, but the protocol specifically states.
That is correct. You may start to get a response after one half. If you want to push both, it's all going to end up in the same nasopharynx airway. That's fine. You can do half and half. Push it in. You're right. The protocol says half and half.
Why does it make a difference? Why does it specifically state that?
I don't think so. Once you understand the anatomy, it goes to the same. I guess theoretically, you're going to increase the surface area for absorption. So instead of saturating this, you can spread it out between both sides of the nose. It's all going to go back. So that's fine.
Was there any way that potentially one nostril could get blocked? So if one's blocked.
Sure. Somebody has cold, obstruction, absolutely. Absolutely. Yes.
What I do for a living, a lot of times you'll see one side of the nostril, might only get it up maybe about that far when you're doing certain tests. The other nostril, you can get it all the way up, you get it that far up very easily. And I think that might be part of it to get better mucosal permeation with finding that one side that really opens it up.
Now, yeah, deviated septum. Now, I will teach you this about the nose anatomy. When you want to put something in the nose other than your finger, because I know you do it regularly, you don't go up, you go back. Okay? So that's where this MAD device is going to go. If you go up here, it's all going to come back out, because there's nothing up here. The rest of the nose is in the face. Don't spray it up, spray it in. Make sense? So you talk to the nurses. You put an NG tube down. You don't thread it up here. You're going to push it up into the brain. You go in. It's the same thing. Okay? And if you think about it, when you go home tonight, you just examine yourself and you'll find where the hole goes. Trust me. I'm a doctor. I know these things. That's what many years of formal medical training has taught me. All right, so we're almost at the home stretch. Last medication is epinephrine. Okay? You may hear it also called adrenaline. That's the British term for it. Doesn't matter. Same thing. If you go to England, they'll say, "What are you talking about, epinephrine?" It's adrenaline. So basically what it does is the peripheral blood vessels, it makes those blood vessels tighten. It takes the airways in the lungs, it opens them up, it makes your eyes really, really big, and it increases your heart rate. So basically it has this fight or flight syndrome. So if you think about it, if you're walking through a forest and a bear jumps out in front of you, the feeling that you have right before you get eaten, that's fight or flight. Including the peeing of the pants. So your eyes are really big, your heart's going really fast, and your muscles are ready to run. That's epinephrine, and it doesn't take long. The indications for giving epinephrine is anaphylaxis. That's a medical term for a really, really severe allergy. We see it a lot in peanuts or bee stings are the common ones. And when we talk about anaphylaxis, to give epinephrine, it's to the point where they're having a hard time breathing. Now, so where does that point turn into where, well, they're working hard to breathe versus, oh man, I'm worried about them, I'm going to give them some epinephrine? Because you talk to most patients that have gotten epinephrine, and just like albuterol, they're really jumpy. Same type of mechanism. And that's a clinical judgment by you. The counsel that I would give you is, the point at which I give it is when they're starting to get tired, and I don't want to wait for them to crash, or when I can hear wheezing through the entire respiratory cycle. What that means is, remember that breathing is 2 phases. You breathe in, you breathe out. With asthmatics, they wheeze because the airways are tight. They wheeze when they breathe out. Very rarely do they wheeze when they breathe in. When I hear somebody that's wheezing when they take a breath in, I get very nervous. Bad things are about to happen. This is when I would give that drug. Okay? So if you hear wheezing when they breathe in and when they breathe out, it's time. And let them know, all right, you're going to feel a big jolt of energy and your heart's going to start to race, but I think you're going to breathe a little bit easier. I'm right here with you, okay? Because this is not a minor thing that you're about to do to them, okay? So the side effects, rapid heart rate, blood pressure goes up. In fact, in certain people, it can be so bad that it can cause a heart attack. They'll feel anxious, they can get a headache. They can also get nauseous and have vomiting. So the contraindications are their blood pressure is already skyrocketing high. That's when you call medical control and say, holy crap, they've got a blood pressure of 185, they're having a hard time breathing, should I give them epi or not? And we will step you through it. If they're pregnant, please call medical control. This gets really dicey. Anything with pregnancy gets really scary, and it can cause complications, including a miscarriage. So I want to keep you safe. I want to keep the patient safe. Let's make that decision together. I don't want you to feel the weight and the responsibility of that decision. Let's do it together, okay? It can also cause arrhythmias, meaning their heart starts to beat in really goofy rhythms that can cause problems. It is what it is. And that's why I just tell people, you need to know. Now, if they've got a pacemaker and they're on a whole bunch of heart medications, this could get really dicey. And again, just call medical control and we'll go through. All right. So cautions about pregnancy and chest pain. So the way you do it, there are 2 doses. There's a pediatrics dose, okay, if you're less than 30 kilos, and then an adult dose. So if you're over 30 kilos, you get the adult. If you're under 30 kilos, between 15 and 30, you get the children's dose. If you're under 15 kilos, call the doctor and let's work through it together, okay? So it's really cool. There's 2 doses, and those doses are right here for the District 10. We have them all right here. So you don't have to do any math. And the cool thing is that the medication is a 1-to-1 relationship. So what I mean is, for adults, you want to give them 0.3 milligrams. Well, this medicine is concentrated to set at 1 to 1,000. So what that means is that if you draw up 0.3 milliliters of this medicine, that will give them 0.3 milligrams. It's the same dose. Do you see the math? If you want to get 0.3 milligrams, draw up 0.3 cc's. And the cool thing is, the syringe, there's only 1 syringe in here. We put this one in. So the maximum dose on here is 1.0. So you're going to draw 0.3. Okay? And then if it's a kid, you're going to give them 0.15. So half the dose. So we've set this up so that hopefully you don't overdose the patient, because you can, and you can kill them. Okay? So 0.3 for an adult into the syringe, and you draw it up from this multi-dose vial. So how do you give it? All right, here's how you give an intramuscular injection. Notice on the right, this says intradermal. That's within the skin itself. We don't do this. Subcutaneous is beneath the skin. Don't want to do that. We're aiming for muscle. This is where it's all at, and that's where you want to stick the needle. So you want the needle to be perpendicular to the skin, 90 degrees. So what that means is if you're going to give it in the deltoid, the muscle's going like this, so your needle should be like this. 90 degrees. Not like this, not like this, not like this, straight in. And the needles that we've put on here, the length of these needles, there's a short one and a longer one. Use the short one for the kids, the longer one for the adults. Okay? And you can't just like, okay, I'm going to poke you. Don't move. Just stay right there. You take this thing and you shove it in, and you can hub it. Okay? Hub it all the way. Get the whole thing in. Okay? And you'll be in muscle, so we don't. Okay? And so you're going to record seeing kind of stuff that we talked about. So what you do is you attach the syringe to the needle. You pop the top to the vial. So you just use your thumb and you just get underneath this lip and you pop it up and it will flip off and you'll see this little rubber stopper. You scrub the rubber stopper with an alcohol pad that is in this box. You stick the needle in the vial and draw up however much you need. Okay? Like we said, just like that. And then you're going to stick it in the muscle. And here are the places where you can stick it. The most common ones are the lateral aspect of the shoulder and the anterior portion of the thigh. So you may run into people that have known allergies and they carry EpiPens. And it's the same thing, it's the same dose. And it's designed for them to pop the top and just jam it into their thigh. Through the clothes, everything. They just go right in like that. So that's what they're doing, it is in their thigh. Most commonly in medicine, we do it right here on the lateral aspect of the shoulder, in the deltoid. Okay? You can give it in the back. You can give it in the hip. You remember when you were a little kid and the nurse said, drop your drawers, I'm going to give you a shot. That's what they're doing. We're not going to ask you to do that tonight. We're going to keep it PG. Okay? So here's the most common place is right here in the lateral aspect of the deltoid. And again, remember, you've got to be 90 degrees and just go all the way in to get down to this lower muscle. So how can you tell? That's usually the question is people are like, how far do I go in? You know, and you know, it just kind of depends. You know, skinny people that, you know, are, you know, it's not going to be much skin and fat to go through. Muscular people, obviously, it's like, well, the muscle's right underneath there. It's the really obese people, you're like, well, I hope I get all the way through, and you hub it. But for most of you tonight, you probably won't have to hub the long needle. In fact, you have somebody to thank back there who only brought the short needles tonight for you. Bunch of pansies. So, here's how you do it. You roll up the sleeve, you take an alcohol wipe, and you scrub off the skin, rub it off, let it dry for 10, 15 seconds. Okay? Then, hold the arm, if you're right-handed, and hold it like a dart. Don't throw it. Hold it like a dart. Hold it like a dart. And just go in like this. Where it really hurts is if you're scared. It hurts is if you go slow and just go, that's what the CIA does. To torture people, it's like, I'm going to go real slow. This is only going to take a minute. You want it to be a fraction of a second. Boom! In, and get it in there. And your hand is going to rest against them to stabilize this. So you bring your hand up, stabilize it against the skin, and then the next step is, come on up here. I need an assistant. All right, come on up here. I mean, this is my fail-safe. He's like, I feel like I've known him since, like, birth. So you come up here, so here's the top of the arm. You don't want to come down to the mid biceps. That's too low. Just up here in the meaty part, you're going to come up here and just go in. Then I will hold this needle with my left hand, again, because once it's in, if you tilt this, that person's going to let you know. Basically, you're pivoting a sword underneath their skin. That's going to hurt. So once you're in, you're going to take back and you're going to pull back on the plunger. Because what we want to know is the very tip of the needle, did you just out of blind luck happen to end up in a blood vessel? Because we don't want to put this in a blood vessel. So you pull back a little bit, and it'll be kind of hard. It's like a suction, and that's good, because if you see blood flash into the barrel of the syringe, you're in a vessel, pull back out, throw the sharps away, and start over. Once you're in, you pull back, and you're like, it's kind of hard. You're in the right place. Then just push it in and come back out. Come back, just straight back out. And remember, you got a sharp, so follow the sharps precautions. Don't stab you. Don't stab your partner. Don't stab them again. They only get it once. Okay? So check the plunger and then put a Band-Aid over it. And that's it. And guess what? All of you get to do this tonight before you go home. So, buddy up. Roll up your sleeve. Each of you buddy up. And you're going to inject the other guy. We have to practice this tonight because this is a critical skill people have to know how to do, and I will throw it around and help you. And trust me, everything's going to be okay, just like this. It's going to be okay.